اوكي. بسم الله الرحمن الرحيم. بنرحب بحضراتكم جميعا في مؤتمر راينو ماسترز 2020، وبنشكر الساده الحضور على تشريفهم لينا وقبولهم التحدي اللي احنا نقدر نعمل المؤتمر في ظل الظروف بتاعت كوفيد 19، ونتمنى ليكم اللي انتوا تستمتعوا سوشيالي، ودي اهم حاجه، وفيزيكالي، وباللكتشرز ان شاء الله اللي احنا هنبقى موجوده معانا السنه دي ان شاء الله في المؤتمر. المؤتمر السنه دي يمكن له طابع مختلف شويه، هو في جزء فيزيكالي زي ما حضراتكم شرفنا، في جزء هايبريد. الهايبريد احنا معانا الضيوف الاجانب موجودين اونلاين وشايفيننا وسامعيننا دلوقتي، فده يعني هو موجود اونلاين، وفي نفس الوقت محاضراته موجوده بتتذاع معانا في نفس الوقت. ونتمنى من الله سبحانه وتعالى اللي احنا نكون عند حسن ظنكم، ويكون مؤتمر ناجح وتستفيدوا من المادة العلمية اللي احنا هنقدمها لكم. I want to welcome Dr. Alkis from Italy. He is online with us from Italy now. And I would like to present him that he will present his topic now. And I want to say to Alkis, hi Alkis from Italy.
Hello everyone.
Hello Alkis, how are you?
Nice to see you. I'm good. I'm safe. Thank you. Hope the same for you.
Welcome to you online with us. It's our pleasure to be with us today, Alkis. We want to hear from you and say hello to all the Varese group and Professor Castronovo in Varese.
Thank you.
I know this is a working day in Varese now.
Yes.
Thank you again for
Today
your help and collaboration with us. And we want to start your lecture now. You will present your first lectures about the JNA. And you can start it now, Alkis. Okay, go on.
Okay.
Invitation. It's a great pleasure to be again part of the Rhino Masters Congress in Alexandria. Again, I'm very sorry not being able to take part physically in Alexandria, that I like very much. As a city, as a congress, as hospitality. I want to thank again all the professors, Professor Ali Ibrahim, Professor Zayad Mandur, Professor Al-Madani, Professor Sami, very kind people, all of you for attending. And now I will proceed with this lecture about the current management strategies for the JNAs. So I will show you what is our protocol, how we do it here in Italy, in Varese. Of course, we have a diagnostic flow chart starting from the medical history. Age, sex, epistaxis and nasal obstruction are the most common things to take in consideration when you have an adolescent, a young boy with epistaxis. Think always about JNA and take a good look of his nose with an endoscopic evaluation. Check the nasopharynx, the posterior nasal fossa, of course, both narix. It's important to check both nostrils. And when you see a mass that is most likely to be a JNA, please make a CT scan, make an MRI and an angiography, but the message is to avoid to do a biopsy, because JNA, we know it's a very bleeding lesion that may cause you trouble in the outpatient clinic if you try to do a biopsy. So the diagnosis of a JNA is endoscopic, radiologic, but not histologic. So histology, we will have it at the end of the surgery, at the definitive histological report. So as we said, it's the most frequent head and neck tumor in the adolescents between 7 and 20 years old. It's only in males present. It's 0.05% of all head and neck tumors, so it's very rare tumor. Has the highest incidence in Asia and causes nasal obstruction and epistaxis. So it's a benign tumor, non-capsulated, has a fibrovascular component, vascular lacunae with no tonaca propria. In an endoscopic evaluation, you can see, of course, mass that is reddish, vascularized, capsulated, and in the posterior part of the nostril. And of course, you have to differentiate it from hemangioperisitoma, from adenoids, and from hemangioma, that are the other lesions that you can identify inside the nostril of with a vascularization. So the CT scan will show an enlargement of the pterygopalatine fossa, and this is the sign that has been described many years before. So in 1965, the Holman and Miller group described this sign, the Holman-Miller sign, with the enlargement of the pterygopalatine fossa. So you can see that the JNA has pushed the posterior wall of the maxillary sinus anteriorly and creating this different space than the other side. So you have the two sides, and you see this is the growth of the side with the disease. Another sign typical of the JNA is the enlargement of the Vidian canal. That we know that the JNA originates from the pterygoids from the Vidian canal, and is causing an enlargement of the Vidian canal. So you can see in the axial scan that the Vidian canal of this side is completely eroded, enlarged, compared to the normal Vidian canal of the other side. So this is a second sign to keep to keep an eye on, and have the proper diagnosis. And again, you can see also in the coronal scan that there is the widening of the pterygoid wedge, of course, because of its involvement. And this is now described as the Ramaran sign. Ramaran is described this sign, and Janakuram has published a very nice paper in 2017 describing the significance of the Ramaran and the chopstick sign that we will see later on. So coronal scan, check for the erosion of the pterygoids with widening of the pterygoid wedge. You see the pterygoid here, and you see the pterygoid here, okay? Vidian canal eroded and not identified anymore. MRI is an important test, an important examination to perform, and will show you the flow void signal due to the massive intralesional vascularization. So another sign to keep in mind. Of course, you see that this high vascularity makes the biopsies contraindicated. So please avoid any biopsies. So classifications, there are very many different classifications about JNAs. In our clinical practice, we use regularly the Andrews classification, which is one of the most used in around the world. The Radowski classification is another one that is used very frequently. And in the last years also, the Snyderman from the Pittsburgh group classification is having some success as a classification, because reports also takes as a parameter the vascularization of the lesion, so from where the blood is coming from. So regarding the treatment, we have some issues to discuss. So angiography embolization is necessary or unnecessary. There are different opinions in the literature. Surgery, we should use an open approach or endoscopic approach, and when? What about post-op imaging to identify if there is any recurrence or any persistent disease? We should make an MRI or an angiography. So let's go to see a little bit these issues. Regarding embolization, can be avoided. This is a huge debate in Congress. So in an open surgery, there is has been described that there is a blood loss about 2 liters of blood without embolization, and only 700 ml with embolization. So you see there is a very big difference, embolization and no embolization. This is to open surgery. Of course, open surgery, you will have the external cutting, you will have also blood loss from the cutting from around the margin. So this is a more aggressive procedure. The osteotomies, you will have bleeding from the muscles. So I think it's correct that there is 2 liters without embolization. Regarding the endoscopic approach, the studies, the literature describe that there is 800 ml of blood loss when you don't perform embolization, compared to only 400. So you see the endoscopic approach has less blood loss, and of course the endoscopic approach is more delicate, is a mini-invasive approach without any cutting and aggressive approaches to the midface, and this also has a better blood control. However, there is a paper and from Janakiram from India that says that he has mean blood loss of only 67 ml in non-embolized JNA. So it's not our experience, it's Janakiram's experience, that he says that for small tumors, T1, T2, you don't need to do embolization, but you can remove it very well and have very small blood loss, 67 ml. So you can see that the embolization should be performed whenever performed 24 hours at least previous surgery, and of course you should not embolize. Your radiologist and interventional radiologists should be aware to not embolize any branches from the internal carotid artery, because you will risk any intracranial complications or any visual loss. So embolization has to be done between 24 and 72 hours. So regarding the approaches, the endoscopic approach is the most feasible option in our hands in Varese. We perform almost always endoscopic approaches. So we have only some sporadic cases that we have done in the past through an external approach. This is because we have a better exposure of the tumor projection because of the angle views with using the 45-degree scopes if we need. We don't have any interference with the fascial growth due to bone cuttings. There is a less post-operative pain and hospital stay. We don't have any external scars of young boys that may have any issues showing the scars when they grow up and also in childhood. And there is no difference demonstrated between recurrences of JNA after endoscopic or open surgery. So the endoscopic approach is the same as an open approach, meaning regarding the recurrence rates. However, there are some contraindications for the endoscopic surgery. Not all cases are amendable to endoscopic surgery. And these are the case when we have an encasement of the internal carotid artery. So it's not feasible to do it only through the nose. Then when we have a massive vascular supply from the internal carotid artery, it's not possible to do it only from the nose. When we have a residual lesion after surgery that has been left on the internal carotid artery, on the optic nerve, near to the cavernous sinus or inside the cavernous sinus, or if you have any infiltration or involvement of the dura. Again, the extension laterally inside the cavernous sinus. So all these contraindications suggest to have an open approach. So the endoscopic, the approach is according to Fish type 3 to reach the infratemporal fossa and the nasopharynx through a lateral approach. So when we do the endoscopic approach, but it's the same also for the endoscopic approaches, it's very important to remove the tumor, and we do the dissection, pulling the tumor. The tumor is capsulated. It's not an infiltrating tumor. So if you pull it, it will come out. The second step is to identify the vascular supply, the maxillary artery, mostly the internal maxillary artery, clip it, coagulate it, and cut it. And at last, identify the Vidian canal and drill it very well, and the basis sphenoid removed and drill it, because this is the area of origin, the area where the angiofibroma is growing from, and you may have some nests inside the cancellous bone of the pterygoid, the cancellous bone that will give you a recurrence of persistent disease. So this is a very important issue. So regarding the surgical treatment, our standard procedure has 3 main steps. So the dissection of the tumor, and of course you see that the JNA is a tumor that is capsulated. It's not an infiltrative tumor. It goes around the different places around the nose, but has not the real infiltration. So if you can pull it from the capsule, it will come out. Then the second step is to do the vascular clipping. So identify the branches that supply the tumor, identify the maxillary artery, the internal maxillary artery, clip it and coagulate it, and then cut it in order to avoid any post-op massive bleedings that may cause you some trouble. And at last, the last step of the surgery is the drilling of the Vidian canal. So you know that the JNA is coming from the cancellous bone of the canal. So if you leave any nests of the tumor, at that point you will have a recurrence or a persistent disease. So it's very important to drill out the basis sphenoid, the pterygoid wedge, the pterygoid basis, and the Vidian canal. And again, here you see this case as the Vidian canal is drilled and has been clearly demonstrated, described, that is involved and has an impact on the recurrence of the tumor. So it's very important to drill it out until you reach almost the anterior genium of the internal carotid artery to avoid recurrence. So how to ensure radicality? The important approach to reach the pterygoids, to remove the JNA, is to have a transpterygoid approach. So the transsphenoid transpterygoid approach needs in advanced tumors, a maxillectomy. In very small tumors, a T1, you may also do it with a very wide anthrostomy, so a type 1 transnasal maxillectomy. However, in big tumors, you need to do a type 3 or maxillectomy with removal of the medial wall of the maxillary sinus, drilling of the piriform aperture in order to gain access to the pterygopalatine fossa and remove the tumor. So this is the Sturman-Canfield approach, as has been described, as you know, that will need to remove the piriform aperture. This will give you the access from the endoscope to go lateral and be able to treat this area, the infratemporal fossa and the pterygopalatine fossa. So this is very important, and you have to plan when you have your preoperative images, your CT scan and your MRI, to plan the surgery, and depending on the site and the extension of the tumor, decide which is the best approach to do and perform for, of course, for the patient and for the surgeon. So let's go to see a first case. This is a stage 1 JNA. This is a 16-year-old boy having, of course, nasal obstruction and recurrent epistaxis. And you see this is a small tumor that has is almost only inside the nose, has an involvement of the sphenoid, of the base of the floor of the sphenoid, and not a very big extension in the pterygopalatine fossa. You see, it's a little bit widened, considering this one. So let's see the video. And you see here, this is the tumor, this is the mass going to the nasopharynx. So we start by removing a little bit the middle turbinate, not all the middle turbinate. We do some plasty, we preserve the superior part, and we open the maxillary sinus. We do the wide anthrostomy to have the landmark of the posterior wall of the maxillary sinus, and then we go to remove the posterior part of the septum to gain access and also work from the approach. Now you see we detach with the laser. We use a dyed laser, the tumor that has some scarring, some adhesions on the lateral wall. Then we enter the sphenoid sinus. We extend the sphenoidotomy laterally. We have to identify the lateral recess of the sphenoid, and you see now we pull the tumor out. Of course, we cut with the sphenopalatine artery. The tumor didn't have any good, any big extension in the pterygopalatine fossa, so we coagulate the sphenopalatine artery, and then now you see we drill the vidian. This is the vidian, okay? So we drill it out, and we had 200 ml of blood loss and no transfusion. Of course, this case has been submitted to preoperative embolization. In all our cases, we do preoperative embolization. This is our thought. We believe that it's better to do it. And you see also that although we had the embolization, we had 200 ml of blood loss. This is the post-op. 72 hours after surgery, we perform MRI, and after 3 months or 6 months, when he will have another MRI, and to check, because this is the time that there is no any inflammation, no any edema that will may confuse your vision of the MRI, and you can check it and compare it to the other one to see if there is any changes or any residual or persistent disease. A stage 2 JNA, and now you see this is a JNA that is a bigger JNA. There is here the erosion of the pterygoid wedge. The tumor is going inside the pterygopalatine fossa. There is the widening of the pterygopalatine fossa. Of course, the patient had a successful embolization, a small tumor, and a very good embolization. You see the pre and the post embolization images with a very good control. And this is the surgery. We start again with the plasty of the turbinate. So we don't, we remove the turbinate. We try to be, not to remove all the turbinate, just to leave the upper portion. This is the tumor inside in the nose at the level of the nasopharynx. The sphenoid has been opened. You can see here the optic nerve and the opticocarotid recess. So we go to remove the posterior part of the septum and detach the tumor from the rostrum and gain access also from the contralateral nasal fossa. Okay, you see here, removing the vomer and the posterior part, the posterior third of the septum. We drill it and we coagulate it. We use the DC bipolar from Microfrance. You see, this is a very good bipolar. Of course, we use that laser to cut all the tissues that are very stiff. Now we have to open the pterygopalatine fossa a little bit. We enter inside the pterygopalatine fossa. This is a Citelli forceps, like a Carrison one. And you see here, we clip the vessels and we cut them. Clip and cut. And coagulate, or you can do all, because sometimes the clips can be removed spontaneously. So you see here, the internal maxillary artery has been clipped, and now we remove the tumor, we pull it. Okay, you see here, we pull it, and then the tumor is being delivered from the mouth. And now we then drill the Vidian canal, as you see here, and the pterygoids and the basis sphenoid to obtain the radicality. Okay, you see here, we drill all the bone. It's very important, the most important thing. Drill the cancellous bone of the pterygoids. So this case had a 300 ml of blood loss and infusion. Very nice, control, final endoscopic vision after surgery. This is the MRI after 72 hours, and you see here there is some liquid, some blood, and however, there has been no any disease left there, and this is after 18 months. Okay, you see how well it has been healed, and there is no any evidence of tumor of JNA left there. Okay, very good result. This is a stage 3 JNA, and you see this is a 26-year-old male that he arrived with this swelling in his left temporal region, not so much epistaxis, and you see that is a tumor that is mostly inside the infratemporal fossa, extending to the temporal region, and not so much inside the nose. Not so frequent case. So you see, has pushed the pterygopalatine fossa anteriorly, and has extended laterally to the temporal region. So he underwent a embolization, super selective catheterism of the vessels, and he had embolization with PVA 200 to 250 micron particles. And you can see in the post-op that he had a very good embolization. Of course, this is something that the surgeons appreciate very much, to have less and less blood in the field. So this is a case that goes very lateral. We cannot do this surgery without doing a medial maxillectomy, type 3, medial maxillectomy, cutting the nasolacrimal duct, drilling the piriform aperture. We cut the turbinate, we do a complete ethmoidectomy, opening the sphenoid, sphenoidotomy, and widening of the sphenoid. You see again the clivus, the carotid, the optic nerve, and we remove now, we enter the maxillary sinus. You see now, this is the tumor. So we have to cut it, debulk it a little bit, because it's very big and we cannot be able to remove. So you see, here we pull it. So if you pull it, the tumor will come out. So sometimes it may break and you may leave a residual tumor. So double check that you didn't left anything. You see some bleeding coming from the pterygoid plexus, venous plexus. You can put some surgical or some flow seal to control this and remove the pieces of the tumor one by one. This is the internal maxillary artery. It's clipped. This is the median. The median has been drilled. And here you see we complete the drilling of the pterygoid and the median again until we reach the carotid artery. Sorry, I show you the control. This is the post-op control. And you see here the good healing. Of course, there will be a scar. We drilled the bone. We did the maxillectomy. We removed the mucosa. So there will be some scarring, but there is no any evidence of tumor. And you see also in this MRI that is very clear and there is no any evidence of relapse. So this is another case of a 13-year-old male that he had epistaxis and bilateral nasal obstruction, of course, and he came to our outpatient clinic, was referred to us, and you see what the big tumor is after we identify. You see how big, going in the temporal fossa, extending bilaterally, and both the noses by pushing the septum. You see how, look how the septum has been pushed from the tumor laterally. So a real mess. Extension to the parapharyngeal space also here. You can see how it goes down, not only the infratemporal fossa, but also the upper parapharyngeal spaces have been involved. So the patient underwent the pre-embolization 24 hours before surgery. Was very nice, the result. You see our neuroradiologist, Dr. Andrea Giorgiani, is the one that mostly does these embolizations, and he is really good, and you can see from the results. And of course, such a case could not have limited blood loss. And as you can see here, this patient had 1 liter and 500 ml, so 1.5 liters of blood loss. Of course, he had blood transfusion with 3 units of red blood cells. the surgery requires the bulking of the tumor. So with a laser, we cut the tumor with a laser to make it smaller and smaller and smaller in order to identify the landmarks inside the nose, some landmarks, because everything has been pushed from the tumor and everything is different. Nothing is the normal anatomy. So once we have removed this, again, we do a medial maxillectomy because we have to go to explore and identify the infratemporal fossa. So if we want to go lateral, we have to do medial maxillectomy. And you see, we are inside the infratemporal fossa. And now the tumor, we pull it. The tumor is coming. And then it's so big that we have to push it to the mouth. Okay, you see, look, it goes down to the mouth. Also, it's not even very easy to pull it from the mouth. So we cut it again from the nose to make it smaller. So some flow seal, some cotton oil, some decongestions for controlling the bleeding from the placoid plexus. Okay, now it's smaller and now we can, deliver it from the mouth. This is the last part from the upper parapharyngeal space, you see? Okay, now pulling it, here it is. Okay, so very important not to forget that there may be any residual parts. This is the pterygoid, medial pterygoid muscle. Not forget that you may have any residual masses left there and remove all the masses, please. Of course, drilling of the Vidian canal, we saw it and we say it again because it's very important. This is the post-op after 2 days, second post-operative day. He still has the packing inside the nose. Very nice control. You see that there are not anymore the masses extending in the infratemporal fossa or going down to the upper parapharyngeal spaces. After 2 months, this is the post-op. Nice healing. There is still some crusting, but it's quite good. Some edema here on the sphenoid area, but no any residual masses are seen. This is the optic nerves, okay, the opticocarotid recess, and nice control. So this is the case, a case of a stage 4 JNA. This is a boy, 15-year-old boy that had pain and mid-facial displacement. So he was very disfiguring, and you see the tumor extending in his face, coming in front. He has extension in the cavernous sinus, with pushing the cavernous sinus. So a very big tumor that we did through an endoscopic approach. Of course, embolization again, being successful, and again, we debulked the mass as much as possible. This case had 2 liters of blood loss. So he had 6 units of red blood cells. You see the opening of the cavernous sinus. When we pulled, the cavernous sinus opened there, and he had a massive bleeding and blood loss. So 3 units of fresh frozen plasma and 6 units of red blood cells were done. We pull and we pull, and it's coming out. So you see, and this is a CSF leak. So this video wants to show you what may happen as a complication of this surgery. Remember that you may have, of course, blood loss, a very big amount of blood, and did a skull-base reconstruction with fascia lata intraoperative. This is the post-op, And you see, we were able to have a good control. The boy was lost, and we don't have any further follow-up because he was coming from Yemen, and he left and he went back to his country. So we don't have any information of what happened to him after months from surgery. So this is our post-op management. What to do? We do evaluation in the outpatient clinic every 3 months for the first year. Then we extend every 6 months for the second year. And then from the 3rd to the 5th year, once a year. The MRI, we do it initially after 48 to 72 hours after surgery in order to have the baseline, to have a basic MRI to compare with the ones done before. And then we do one every 6 months and once a year after us for the follow-up, endoscopic follow-up. So, of course, the frequency depends if you have any residual tumors or if you have any complications, how many frequently you will have to do the MRI. If you perform CT scan, what to check? You have to check the chopstick sign as described by JNA Kiram, which is this sign, meaning that you have drilled very well the pterygoid plates that are, there is a disjunction and there are 2 parallel lines. This is the chopstick sign, meaning that you did a good job drilling very well the Vidian canal. What about the residual tumor? So we have different options depending on which are the critical areas that the tumor is, if it's near to them, if there is a great a rate of growth of the tumor during the follow-up, so if you see it growing or if it remains stable, and what are the symptoms of the patient. So depending on these 3 points, we may have surgical revision, we may have a radiotherapy, but this will have a collateral effect, especially if you do it in critical areas, a gamma knife radiosurgery, a wait-and-see policy, or there is some promising role of the therapy with estrogens and androgen receptor blockers. So this is some new studies coming out and still to evaluate. In our experience, this is our case series until February 2020 when the pandemic came out. We have operated 78 cases. And we use, of course, as I told you, the ENDOS classification, and you see that most cases are cases stage 2 or stage 3A, because, of course, these are the indications when you start JNAs progressively. You start from stage 1 to stage 2 to stage 3A, and now we push the limits with our experience slowly to treat also stage 3B and stage 4 cases through an endoscopic endonasal approach. We have 9% of persistent disease, 9%, and 77% had preoperative embolization. Only 16 cases had blood transfusion. What about approaches? Pure endoscopic approach was the most frequent one, 97%, as I told you. We have a mid-facial degloving, just one case. This is an old case. A paralateral approach, just one case. And all cases have a median follow-up of 68 months. So in conclusion, the introduction of the microendoscopic surgery has led to a revolution in the management of the benign tumors of the sinonasal tract and the nasopharynx. So if we think about inverted papilloma, and of course this has been extended to JNAs, and microendoscopic surgery has been considered an appropriate treatment for type 1 and type 2 tumors, and of course most of type 3A JNA. So if you are an experienced surgeon, you can approach them. If you are a beginner, when you have done a lot of functional endoscopic sinus surgery, then you can start to approach type 1 JNAs. Refinement in surgical technique as well as in surgical instrumentation will make possible to extend the indications to type 3B and 4 in more proper way. And of course, the periodic endoscopic and radiologic evaluations are recommended in order to detect very early any residual or recurrent lesions. Thank you very much for your attention. I invite you again in our Congress of the National Skull-Base Society, Italian National Skull-Base Society, 2021, November, from 11 to 12. We will be very happy to have you. The president of the Congress is Professor Castelnuovo, my chief. And if you are interested on having a basic course on sinus surgery, this is the link that you should check at tingoedu.it, and you will find all the information about our courses. The next one will be on November, a basic course, and soon we will have all the information about the courses in 2021. Thank you again. Thank you very much.